Welcome to the Healing Pain Podcast with Dr. Joe Tatta. Each week, we interview top experts in physical therapy, pain science, and integrative pain care. You'll learn the most up-to-date information for treating and reversing persistent pain. This podcast is for educational purposes only and not intended to be used as personalized medical advice. And now, here's your host, Dr. Joe Tatta.
Hey there, welcome to this week's episode of the Healing Pain Podcast. I am your host, Dr. Joe Tatta. It's great to be here with you again. Each week on this podcast, we generally discuss the impact of physical therapy treatments for the management of chronic pain and other chronic diseases. From there, we have explored other overlapping problems and conditions, such as things like opioids and the overprescribing of opioids or addiction, and the movement to choose physical therapy as an alternative to opioid medication. A clear movement also exists for physical therapists to play a more pivotal role in treating and managing non-communicable diseases such as diabetes, metabolic syndrome, hypertension, and cardiovascular disease. This shouldn't be too much of a leap because as physical therapists, we have had a specialty in cardiopulmonary physical therapy for many decades. But something happened during the COVID-19 pandemic, which changed our profession, as well as changed our personal lives. America's mental health declined, with anywhere between 28% to 40% of adults struggling with depression during the height of the pandemic, and many of those numbers have stayed consistent. More people were prescribed antidepressant medications, and the mental health care shortage intensified, with many providers and clinics having wait lists of 4 months to a year, which left many people without essential healthcare or mental health care services. As licensed doctoral trained healthcare professionals, we physical therapists, whether we realize it or not, see people with mental health concerns daily in almost every practice setting. And our profession, like many others, have begun to advocate for ways to improve mental health and mental well-being. We now know that the epidemic of depression requires a supporting role by physical therapists. The reason is because the influence of physical therapy extends way beyond the physical benefit. It improves mental health and promotes mental well-being. Screening and addressing behavioral and mental health concerns is within the scope of physical therapy practice guidelines. The American Physical Therapy Association published these guidelines in 2020 in a House of Delegates position statement. And this position is generally in line with best evidence and the growing trend in psychologically informed physical therapy, which incorporates biopsychosocial treatments for chronic pain and other health conditions. Now, almost 2 decades before the American Physical Therapy Association published these guidelines, there was the International Association for Physical Therapy in Mental Health, which is a subchapter of the World Confederation of Physical Therapy, who describe the need and scope of physical therapy in mental health, behavioral health, and psychiatry. And really what we're seeing is the construct of psychologically informed physical therapy is the same or similar to or complements mental health physical therapy, which is used to facilitate body awareness, problem-solving skills, cognitive restructuring, and ways to cope which reinforce self-efficacy and improve quality of life in the face of poor mental health. It would then appear inherent that a physical therapist can use biomedical treatments as well as psychosocial treatments based on their key role to reduce disability and foster positive human growth. Now, occasionally, as physical therapists, we sell ourselves short, and we fail to understand the depth and the breadth of the impact we can have on someone's quality of life. And what I'm referring to is the emotional and the psychological benefits that can increase the value of care that we provide as individuals and as a profession. And perhaps now more than ever, it's important that we understand and that we can explain the breadth of the therapeutic benefits that we provide, because studies demonstrate that approximately a quarter of all Americans may have a mental health condition. 25% to 50% of patients among a general outpatient physical therapy clinic have a mental health condition, and upwards of 70% of patients with low back pain that report to physical therapy have some level of depression. We are already seeing this in practice. There is a place for us to be primary care and entry point providers into the mental health care system. However, that doesn't mean that we simply, quote unquote, refer out. It means that as professionals, we stay engaged in patient care and we continue to play a role independently or in the co-management in the mild, moderate, and severe depression or other mental health conditions that exist in our populations of patients that we treat. In fact, there's some literature that mild to moderate depression improves over the course of physical therapy, regardless of whether or not a mental health provider is engaged in the plan of care. How can that be, or why is that? It's because movement, body awareness, physical activity, exercise, and many other interventions that we use as professionals are a catalyst for positive mental health and improved psychological well-being. And when you combine physical activity with cognitive reappraisal, there's generally a greater impact on outcomes and the quality of life in the patients that you care for. Joining us today to discuss the role of the physical therapist in treating depression is Dr. Tony Varela. Tony is a physical therapist who brings 20 years of experience in musculoskeletal health, including pain management. His professional principles were paved through residency and fellowship, grounded in rich patient experiences and reinforced by serving those surviving chronic pain, cancer, as well as trauma and PTSD from war. Dr. Varela believes there is a better version of ourselves ready to push through and is currently assistant professor at Arkansas College of Health Education. Tony recently authored a paper in the February 2022 edition of Physiotherapy Theory and Practice called The Theater of Depression, a Role for Physical Therapy, which we'll discuss on today's episode. Okay, without further ado, let's begin and let's meet Tony and discuss the role of physical therapy in the treatment of depression. Hey there, Tony. Thanks for joining me this week.
Thank you. It's great to be here.
I'm excited to speak with you, Tony. I know you recently have published a kind of an article perspective paper called The Theater of Depression, a Role for Physical Therapy. It's in the 2022 Journal of Physiotherapy Theory and Practice. We'll link to that in the show notes. Everyone can read it. It's a great paper that you wrote. And the title, as I was searching through the literature, just popped off the page to me. The Theater of Depression, a Role for Physical Therapy. We don't often hear of there being a role for physical therapists in treating mental health, specifically the condition or diagnosis of depression. And it's one that is becoming talked about more and more in professional circles, in the literature, in DPT education, in continuing education, and of course in venues, public venues like this, that there are both people with chronic health conditions as well as professionals that are interacting, collaborating, and listening in a community environment. Where did I know obviously you teach, you do research, where did the idea for this manuscript originate from?
The title for the paper it was something that came to me as a title that would encompass the spectrum of depression and mental health that physical therapy could be involved with, and to a much greater degree. So I do think we have to accept that there is a role, and the mental health community also has to bring us into that theater or that realm of mental health. And that's one of the reasons why I wrote it. But it's been an evolution in my career and in my understanding of what the psychologically informed physical therapist is and should be. And now I've landed on this idea that mental health is a part of physical health. And if we are going to promote mind-body connection and awareness, we have to embrace the mental health portion of it. And I do think there's a spectrum of mental health issues that physical therapy could be involved with and needs to be involved with, not only from our side as we move into that world, but from the mental health world, willing to open up and utilize us to a much better degree. I hope that answers the question, which I think talks to the idea that it's been an evolution for me, and now I'm trying to promote the idea that it's an evolution for healthcare and mental health.
Well said, and I think it addresses that question as we begin with. And even what you said right there's a lot to unpack, and we'll unpack that as we go through today's episode. So you mentioned, let's talk about a couple of things there. You mentioned there's a role for physical therapy in different types of mental health conditions. So, for example, you're saying things like depression, which is in the paper, anxiety, PTSD, and maybe other types of psychopathology. And then within those conditions, there's also severity. So, for example, there's mild, moderate, and severe depression. And there's a role for, or I should ask you, is there a role for PT at all three of those levels for mild, moderate, and severe conditions or severe disease, so to speak?
I do think there's a role for all three. I think where we can open the door and really drive an impact that shows the mental health community that we should be an integral part of that community would be on the mild and moderate levels of depression, and then utilized accordingly or appropriately once things stabilize with the more severe cases, particularly just isolated to depression, but that certainly would include issues of PTSD and some of the other mental health concerns.
Mm-hmm. Right. So so in that case, we're talking to probably physical therapists and helping them identify that they have a role in mild, moderate, and potentially maybe even severe depression. Absolutely. And then you brought in the idea that you'd like to have mental health professionals bring our profession, so to speak, into or under the umbrella of mental health treatment. And I've heard, because I've spoken to many mental health providers on this podcast and support the work they do, but I've actually heard many licensed psychologists and mental health providers on this podcast say things like this. Once the patient's pain decreases, then I can refer them to physical therapy. Or once their depression gets better, then I can refer them to physical therapy. And as I listen to them, because I'm on a podcast, I don't necessarily want to, kind of disparage too strongly about what they're saying, or maybe even some of their research. But I think there's this idea of if pain goes away, then I can exercise. If depression decreases, then I can engage in a physical activity program, where we have to educate the public that these two things can exist at the same time.
Absolutely. And the paper speaks to that. The idea that exercise, just in general, but exercise delivered by the physical therapist is considered ancillary or a alternative medicine.
Yeah, the word ancillary, Tony, just drives me up a wall, basically.
Absolutely.
Ancillary sound, and I'm telling you that because we're talking peer to peer. The word ancillary to me sounds like, well, we don't really need it, but we'll allow it to happen, basically.
Yeah, exactly. And I think it's time to actually include us as colleagues that can contribute to not only the full diagnosing of depression, because there are physical impairments and there are levels of disability that directly relate to the levels of depression. Why not get involved from the very beginning? And I think the idea of eliminating movement and physical awareness from the rehab process of mental health may actually be doing them a disservice. I mean, I would go on record, I have with the paper, to suggest that clearly whatever has been going on to date hasn't been working. And it requires, at the very least, rethinking the patterns that have gotten us to this point and how they can change.
Right. So rethinking, for example, because we're talking about depression, the guidelines for depression are CBT or antidepressant medications as a first line of treatment.
Right.
Works sometimes. And the research.
Yeah, and like I said in the paper, it's even the pharmacology or pharmacotherapies, for in all intensive purposes, are a blunt instrument that really help a few individuals.
Right. So, for example, as first line therapy, you're potentially suggesting that physical therapy could be added to the first line treatment of something like depression, where, let's just take exercise. And I want to place that there lightly, because there's a lot more that we do as professionals than just therapeutic exercise.
Absolutely.
But we know that the research on exercise for depression is quite strong.
Absolutely.
Right. And if you combine exercise with cognitive behavioral techniques, that the impact is probably greater.
Absolutely. Yeah.
Right.
And the reappraisal of the sensations and the movement patterns and the self-awareness, combining again the cognitive behavioral therapies and the therapeutic exercises, I think really enhances whatever other psychotherapies that they've been receiving and going through, as well as maybe enhance the application or efficacy of the medications.
Right. So if our treatment can enhance the outcome, then it shouldn't be looked upon as ancillary.
Absolutely.
Yeah.
Yeah, I actually have a hard time wrapping my mind around the idea that that word is still being used with physical therapy or occupational therapy.
Yeah. So as you were starting to put together this manuscript and you're outlining it and you're doing the research, was there a concern about how the manuscript would be received by our peers within the PT profession, or maybe perceived by other colleagues outside of the physical therapy profession about, hey, here's a physical therapist talking about the treatment of depression. Hey, maybe this guy's a little bit outside or he is outside his scope.
Yeah, absolutely. Writing, it did come with a certain level of anxiety on my part, because I'm putting myself out there and kind of going against what seems to be the status quo here in the United States. And I did have an apprehension about suggesting the challenges with our current state of affairs in mental health. Mm-hmm. And I didn't want it to come across as disrespectful in any way, because I think the intentions are genuine. And I think the purpose, the purposes that drive the other disciplines is genuine. What I'm concerned with is, why aren't we willing to discuss the challenges that they face, and why aren't we invited into that conversation? So in the end, I landed on the idea that to not publish it or to not make the suggestion was probably more of a disservice than to hold back those thoughts. But it really it does come from a place of respect for all disciplines. I think we all have something to contribute. And now it's time for physical therapy to be offered the opportunity to contribute to a greater degree than we have.
So you mentioned the perspective, or the potential perspective, of a growing trend now called mental health physical therapy, or mental health physiotherapy, which probably started somewhere in the Northern European countries. I know I've come across some of their literature when I wrote my paper on mindfulness, which is in PTJ, and I know you've come across it on this manuscript that you completed, is now published in Physiotherapy Theory and Practice. What are the differences, or what was some of the eye-opening moments that you saw when you were writing this manuscript, and also what physiotherapists are potentially doing in those northern countries in their perspective versus what we're doing here in the United States?
It was an eye-opening endeavor for me to really get the nuances. And that's been part of my evolution to understand the psychologically informed physical therapist. With that being said, we're looking at how mental health, or say depression specifically, is being diagnosed. And it's being diagnosed through psychiatry and psychology. More importantly, it's being diagnosed in primary care. So they are the gateway to mental health. And the idea is that many times the expressions of depression are so unique to the individual that there are probably a lot of cases that are overlooked. as a mental health issue because the expression seems to exaggerate pain or disability as opposed to despondence and despair and a sheer negativity on life. And I think that actually carries over into physical therapy, where we will see somebody exaggerate their pain levels and focus on levels of disability and poor movement strategies as the issue, but there is an underlying cause that's directly related to their mental health, and that's established in the paper. And I think that we need to open up our eyes to understand the correlation between those mental aspects and those physical impairments to a much better degree. So I'm not sure that I'm answering the question, but just to reiterate it, the idea is we're probably already more involved than we give ourselves credit for. And there's an aspect that's being overlooked by the mental health community that should be an eye-opening moment for them to invite us into the conversation. That was probably the most enlightening aspect of the paper. And I trust that makes sense, right?
Yeah, let's talk about that a little bit, because I know what you're saying, because I've read some of the research on that. So there have been some studies where they've looked at outpatient physical therapy clinics and surveyed physical therapists about what percent of your patients you see on a daily basis potentially present with a mental health challenge. And I think the numbers are like somewhere between like 40 and upwards of 70%, depending on the practice. So we're seeing that in practice. And you're saying the gateway for that potentially is through primary care, or maybe even orthopedic care, because that's oftentimes how people find us, right?
Right. Yeah, that's exactly what I'm saying. That the majority of those cases going into mental health, if they actually go into it, which is a whole nother discussion,
so
is
that
obviously primary care.
So that talks to the idea. It's not whether we can see patients with mental health conditions or not. We're already seeing those patients in our clinic.
Right.
Some of them may not necessarily be identified through something like the depression and stress scale, for example.
Right. And the challenge goes a little bit farther for us, because I know a lot of clinics do screen for depression, particularly if they're outpatient clinics associated with a hospital, but then they never do anything with that information.
Yeah. The piece that I want to backtrack to a little bit is, you said in primary care, many physical complaints may be disguised as quote unquote mental health conditions.
Yeah.
I wonder if we reframe that more as that there are bi-directional associations between mental and physical health, if that's more helpful for those who are suffering with these types of conditions. Because if we say to people, well, you went to your primary care doctor for low back pain, or you went to your primary care doctor for chronic low back pain, and you were sent to the physical therapist, but it was discovered that you have, let's say, primary depression. It almost sounds, again, like there's not a role then for, let's just call it physical medicine in that person's care. Where if we talk about these conditions as having bi-directional mechanisms between the physical and, let's say, the emotional, or the physical and psychological, then it helps people potentially embrace the idea that, okay, I'm a whole person. And as part of whole health, I have to care for my mental health as well as my physical health. And when I do that, both of them have a positive impact on my well-being and resilience.
Oh, absolutely. And I didn't mean to imply that it wasn't. What I was expressing is directly related to the way that the patients are going to express it. And I 100% agree with you. It is bi-directional, and the overlap between them is absolutely incredible and nuanced. So I think we have to respect the expressions that are important to the person that we serve and the context in which they're expressing it. They might focus on the physical impairments sitting in front of a physical therapist. And I think the levels of disability associated with that individual and with mental health need to be addressed as we would normally address them, but now bring in the cognitive portions and the cognitive functional therapies that are consistent with that.
Yeah.
Yeah.
There are a lot of physical therapists listening to this episode right now. Many of them are interested in mental well-being and mental resilience approaches. And some of this is new for them. If they've been following some of my work, it's probably not new, but there are definitely people who are listening to this for the first time because they said, hey, this is an interesting topic and I want to hear what Tony and Joe were talking about with regard to mental health physiotherapy. Let's kind of play devil's advocate, and I want to ask you a couple questions.
Absolutely.
Some of these will be yes, no, and some of these will be probably need a little more to unwind what we have here. First one, does a physical therapist have a role in mental health?
Absolutely.
Can a physical therapist, for example, treat depression as a primary diagnosis?
I think a physical therapist can treat depression as a primary diagnosis. I'm very cautious to say that the diagnosis of that probably should come from a other professional. So a level of collaboration is required to understand these specific mental health diagnoses that would be provided by a counselor, a psychiatrist, somebody of that nature.
Can a physical therapist screen for psychological and emotional components of health and well-being?
Absolutely. And I've already alluded to that. We already are doing that to some degree. The challenge is we screen for it and overlook it for the most part.
All right, so this is going to be a tougher one because it's going to combine all aspects of what I just asked.
Well, I thought the primary diagnosis one was pretty tough.
So if physical therapists have been identified as primary care providers and entry point providers, can we then evaluate / screen and diagnose, let's say, primary depression?
Therein lies the rub, right? So we want to have direct access. We want to be primary care practitioners. With that comes the responsibility of taking on mental health. I do think that we should take that responsibility on.
I agree too. And I also appreciate you making the distinction between direct access and primary care, because direct access really means that I can see a physical therapist without a physician's referral.
Right.
Where primary care physical therapy really means that I, as a licensed doctoral trained health professional, can embrace a full systems view of the body, know how to evaluate and screen for things, and then triage the patient appropriately. And also reflect on my own personal scope of practice and know that, well, if I have taken, let's say, 10 different courses in mental health physiotherapy, for example, it may be well within my scope of practice to screen, diagnose, and treat this patient and or refer and collaborate if needed.
Right.
Or I may be in a primary care setting where I screen for depression, let's say, identify it, and then refer on to the appropriate mental health provider or licensed health provider to treat them. So there's lots of different, I think people or professionals fall into this, not black and white, they may fall into it in different areas. And as their profession advances, or as they advance their scope of practice and their education, their approach may change as well.
Yeah, and I would go one step further and suggest that if we are going to take on that role, and if we or any individual in the physical therapy discipline takes on that role, they need to also embrace this component of it. As I have suggested, the mental health gateway is through primary care, and recognizing that puts a much a greater onus of responsibility on us to help contribute and manage the challenges that the primary care physicians are going through.
Yeah, I mean, I've heard psychologists say that primary care providers aren't actually very good at evaluating and diagnosing mental health conditions. A lot of people fall through the cracks there.
Oh, yeah, absolutely. And the paper speaks to that as well.
Yeah. Can you
I
talk to
think
that a
for the
little bit?
most part, it's a 50% diagnostic accuracy, if that. And most of the time it's done on a clinical determination without actually a full screening or anything else. And that I think also speaks to the potential door that's open for physical therapy to come in and help primary care in general, right?
Yeah.
I mean, they're busy, they get schedules that are full moment to moment, day in, they have their algorithms, they go through those algorithms, and anything out of that algorithm gets potentially overlooked. And I think physical therapists can help with that.
A colleague and friend of mine, Jeremy Fletcher, who teaches a trauma-informed pain course here at the Integrative Pain Science Institute, he actually says oftentimes that in some parts of the country, in some clinical contexts, that physical therapists are becoming the de facto mental health providers in their area, either because there are not enough mental health providers, or because they're coming through gateways like primary care where they may be improperly diagnosed or misdiagnosed, or we just have a role to fill, basically. If our peers are recognizing, and your research is supporting that in some ways we're becoming de facto mental health providers for certain mental and physical health conditions, why are some of our peers potentially hesitant to take on this responsibility of mental health physical therapy or mental health physiotherapy?
Yeah, I completely agree with that comment that Jeremy Fletcher stated. And I mean, as a good example to that, I believe in collaboration with the other disciplines, which includes occupational therapy, by the way. And with that being said, I've tried to refer some of my patients to counseling and to psychotherapists, and I get the response, I can get them on my schedule in 4 months from now.
Mm-hmm.
Right. So by default, I have to take on a part of that responsibility. I think the challenge of other therapists taking it on is the educational process hasn't completely embraced it. So it might be, the psychosocial and the biopsychosocial and the embodiment theories, social cognitive theories are sprinkled throughout the curriculum, but it's never fully embraced, even though I think some universities now have a biopsychosocial course. Mm-hmm. And may actually involve some of the psychologists as a part of that. So and even though it's also threaded, the psychosocial components are threaded through all of the books that we are teaching from, whether it's ortho or neuro, pediatric or geriatric or whatever. So that's a part of it. The other challenge is, I think there's still this abrasiveness between some of the disciplines that consider us ancillary, consider us as alternative medicines, consider us as the last resort.
Allied health.
Yeah, the allied health components, and do kind of put us in a corner where we're hesitant to fight our way out because of whatever reasons, right? Stepping on toes, the respect for the community. I'm not sure where that goes, but and I think the combination of those three things are the challenge that we face and have to overcome. Education, taking on the responsibility, and then having the patient speak for us. I know when I've embraced it and have taken that on with my patients and those that I serve, they're grateful, right? And they end up spreading the word. And then some of those primary care practitioners end up referring back to me because I was willing to take it on.
Yeah. I think where part of that conversation goes, if I'm hearing you right, is that on some level, we compete as professionals.
Yeah.
Right?
Yeah, I think so.
Even I have a colleague who works in a multidisciplinary pain program with an inpatient and outpatient component. And they frame it as a psychology-led program. And I've always found that interesting. Nothing against psychology, love psychology. But I'm like, psychologists can't perform a physical evaluation. So how would they be able to differentially diagnose, let's say, chronic low back pain from a tumor, let's say, in someone?
Right.
So these are things that just kind of like circle through my mind. And, I know in the university setting and university hospital settings, collaboration is a lot easier. In our capitalistic US healthcare system, we actually compete for patients. We compete for insurance coverage. For example, there are many insurances that won't cover 2 different types of therapies at the same time.
Right.
So there are systemic reasons, I think, why this does occur to some extent, where, obviously the onus may be on the insurance company to provide more coverage, or maybe laws in certain states that would open up, more avenues for us to function in our fullest capacity as primary care physical therapists, and to facilitate this type of conversation that you're opening. If you're talking to your colleagues in mental health, how would you like them to start to approach physical therapists and have this conversation with them around, let's just say, depression, since that's the theme of your paper?
Yeah, and you touched on a few things that I think are also important. Going back to the previous question, the issue of the system itself is a barrier that we have to overcome as well, right? The insurance companies and the way that they see us. And I think a part of that is also, it's a very tough, the idea of the nuances that are associated with mental health and the balance between the mind and the body. It does require a special kind of person, I think. Something to the effect of like pediatrics. I'm not the person for the pediatric patient, but I think I am the person for mental health. And with that being said, that's where I land with this last question, is I would want someone who is interested in that, in physical therapy, to embrace the idea that it does take you slowing down a little bit. It takes an open mind and a willingness to understand an individual from the way that they see life and the issues that have gotten them to that point, both mental and physical. And at the same time, if we're going to embrace the idea of the biopsychosocial components, that we do it with a genuine reverence for the human condition and the spectrum and nuances that are associated with that. We all like to, I know the sports therapists will jump on sports psychology, which might not be any different than the individual who is struggling with a fear of falling, or the individual who is dealing with chronic pain and overlapping depression and distress and anxiety.
Mm-hmm.
It's nuanced, and it requires a special ability to negotiate that emotional and physical traffic between you and the individual that you're serving.
How has your research on this work impacted your personal life?
All I know is a lot of people say I'm a great listener. I actually have learned to slow down and really just hear what people are saying, and I think that's the way that it's impacted me. I do some mindfulness work with my patients. I believe in reappraising the perceptions and the cognitions around it. And I think our behaviors and our movement and the efficiency of our movement reinforce anything that's internal, right? So which are our sensations, our perceptions, our cognitions. So I try to be that within myself and be more aware of it within myself, and really truly walk the walk when it comes down to it. So, with that in mind, what I've also kind of been branching out to, because I think the common threads with mental health and chronic pain also carry over to substance abuse. So, and those common threads are self-efficacy and emotion regulation. And those are aspects that come through with mind-body connections and exercise, therapeutic exercise, functional exercise, as well as mindfulness training. So I would also tell my colleagues that they need to embrace the idea of the mindfulness training as a portion of that. So, and again, we're talking across the spectrum, whether it's spinal cord injury, Parkinson's, chronic pain, and possibly even pediatrics, right?
Yeah, because right now what you're saying is, as a profession, it seems like we're latching on to the idea of psychologically informed care for people with pain.
Yeah.
We've checked off that box, we get that, and professionals have embraced that.
Yeah, and
you're saying, well, chronic pain is only a small part of what we do as PTs, but there's a whole other realm of different practice settings where we function in, most of them you just mentioned, where these skills can be used as well.
Absolutely. And I do think that we've gotten to the point where it's a disservice if we are isolating ourselves to the chronic pain patient. And there's a lot of people struggling out there. And, we can tie it all together with the mental health, the substance abuse, the chronic pain, and then just the day-to-day struggles of anxiety and distress and the associated comorbidities with that, right? So we have a lot of work to do, right, is what it comes down to. And I think we should be a much bigger part of the mental health component across the spectrum of the diagnoses that we would see in physical therapy.
So the American Physical Therapy Association released a position statement, I believe it was 2020, on the role of the physical therapist in behavioral and mental health, which is great. House of Delegates position statement or perspective, we hope gets adopted by state practice associations, which sometimes it does in a direct way. Other times it's a little bit of more of an indirect way. What would you like to see our professional associations, state and national levels, do with regard to moving forward the idea that physical therapists have a role in treating depression?
I definitely think that we need to lobby to a much greater degree to be involved as the mental health team. That's where I land on that. What's interesting is there isn't a mental health SIG. There isn't a mental health physical therapy SIG. And I think maybe that's where we start. Then start to lobby to a much greater degree to have us included or become inclusive to the mental health community. I think we should be colleagues to the counselors, the social workers, the psychiatrists, and the primary care physicians that are all taking care of mental health.
Yeah, and to piggyback on that, there is also the International Association of Mental Health Physiotherapy, which I believe is a group under the World Confederation of PT.
Yes.
And the US is not a member country of that. I know that.
Which is interesting because I did email them and communicate with them to try to make that. And you know who they referred me to you, right? They said, you need to collaborate with Joe and get this going.
Well, I agree to some level. I think The International Association is a wonderful association. They have some really great guidelines. A lot of them we have spoken about in some way on this episode today. I think the challenges in our country, we have specific, as I mentioned before, specific practice guidelines and systemic guidelines that exist within insurances and state laws that are both implicit and explicit, actually, that slow down this conversation at a time where this conversation should really be rapidly evolving, especially in the United States of America in a post-COVID era, where, as you mentioned before, I have multiple friends in the mental health profession. I spoke to them. They said, oh yeah, I have like a 2-month, 3-month waiting list. And I'm like, in the back, I don't say anything because I'm not advocating to them, so to speak, in that moment. They're my friends, not colleagues. But in the back of my mind, I'm like, what are these people with mild to moderate depression doing as they're sitting around waiting for a mental health service to open up? And we know that might not open up the way things are going. Now, to speak about that on a more significant and serious level, we know that when people have a condition, they don't access care, that their symptoms may get worse. And we actually know when people have chronic pain and comorbid mental health challenges that go unaddressed, it actually leads them potentially more towards suicidality. So we need to, and this is why I appreciate your paper and I appreciate this conversation, because as a profession, we need to be a lot more aggressive in what we're saying in our literature, in what we're teaching in school, and the professional conversations we're having online, offline, with colleagues in universities and medical centers, and say, hey, like, mental health is clogged up. I'm not saying I can treat schizophrenia necessarily, but you can send me your patients with mild to moderate anxiety and depression. Exercise and physical activity, along with some cognitive skills that we use naturally as PTs and coaching skills, can actually positively impact that person's health and mental well-being and resiliency as they're waiting to get in to see a mental health provider who can go deeper on the topics that they need to go on.
Yeah, absolutely. And I mean, like the commercial says, right, if you're not getting help here, please get help somewhere.
Right.
And I think we're already doing it to a certain degree. Now it's time to up our game with it so that we are more involved. And clearly the situation has become one where there is a huge fallout and unintended consequences, if you will, of the comorbidities associated with depression and disability, and the behavioral challenges with our mortality, and the progression of the disease process, including mental health diseases, that are going to make it even more challenging in the future if we don't address it now and jump in now. And I mean, it's becoming, and those are the cases that we know.
Yeah.
There's probably a lot of other cases that we're unaware of or we overlook because of some of the physicality that's associated with it.
Yeah, where this came up really early in the evolution of this podcast is I was speaking with Beth Darnell, who's a pain psychologist at Stanford.
Right.
She does amazing work on studying and investigating tapering. And her work obviously shows that when you use some basic cognitive skills to help people taper, that it not only helps with their pain, but it helps them taper off opioids,
right,
in a way that's healthier. And my question is, okay, if we took the millions of people that were on opioids who potentially chose, because obviously if people choose to taper, it's typically it's more successful, but there's not enough mental health providers to help those people taper.
right.
And I'm like, the next best person for that is a physical therapist. And
Absolutely.
we have meta-analyses and systematic reviews that demonstrate we can use cognitive behavioral skills, traditional CBT, whole protocols of traditional CBT to treat pain. Why can't we now expand that to treat pain and help someone taper at the same time, basically? And obviously know the limits of our scope of practice when that taper is not going well. and then to refer someone back to whatever primary care or addiction medicine, whatever it is. Right now we probably have a couple million people that want to taper and don't have the resources to do that, or the professional to help them do that.
Right.
So when I read your paper, there are overlaps, of course, with depression, anxiety, pain, physical health, and then you mention addiction and things like tapering.
Yeah, absolutely. And that parallels with primary care too, who were prescribing the opioids and then in many cases just stopped because of the bylaws and the mandates and other things of that nature. Right. So now they've left a group of people abandoned, for the lack of a better word. And if we're going to accept that primary care role and that responsibility, those are people that we didn't have to abandon. Right. Yeah, absolutely. I agree with you. Yeah, I love Beth Darnell's work, so I follow her as well.
Yeah. It's been great chatting with you today, Tony, about the role of physical therapy in the treatment of depression and other mental health conditions. If people want to learn more about you and your work besides this paper, how can they follow you?
Well, at the very least, I hope that paper is inspiring to a group of physical therapists and occupational therapists as well. And thank you for having me. I don't do a whole lot of social media. I'm actually trying to change that. So I do have an Instagram now and Facebook and a webpage. It's all physical intelligence or physical intel. The webpage is physical-intelligence.com. And the handles are physical intel. But people can also reach me. Probably the easiest way to do it is email. If they wanted to communicate. And I would hope that we can do some work together or get the word out there to maybe start a SIG or to become a part of some of those other organizations that you've mentioned.
Great. We're going to make sure you get some traction on your social media. So if you're listening to this episode and you're on your smartphone or your cell phone, take a picture of the episode. And you can tag Tony on Instagram. And of course, you can tag me on Instagram at Dr. Joe Tatta. And we'll be sure to get some more of our colleagues interested in this conversation and start to open up a broader conversation, not only in the PT world, but in the mental health profession as well. I'm Dr. Joe Tatta. It's been great spending this time with all of you. And we'll see you next week.
Thank you. Thank you very much.
Thank you for listening to the Healing Pain Podcast with Dr. Joe Tatta. To subscribe to the podcast and learn more, visit Integrative Pain Science Institute.com. That's Integrative Pain Science Institute.com. Sign up to receive weekly updates, leave a review on iTunes, and share this episode with your friends.